The diagnosis of epilepsy basically depends on a very good history, a very good clinical history, and then, of course, the examination as well as investigations help you pin down the diagnosis. So, the first and foremost essential question when you come across these patients, when you come across any person who has had episode of loss of consciousness, episodes of loss of awareness, episodes of some funny or abnormal sensation, is you're trying to determine, you're trying to answer if these symptoms represent epilepsy. And what I will do in the next 8 or 10 slides is give you some very basic questions that we typically ask all patients who present to the epilepsy clinic. So, the first and foremost question is, what happens before the seizure? I ask the patient and their family members or other witnesses to help me with this question. So, patients may have no symptoms, no aura, no warning before the seizure, which in that case you may suspect the patient may have had a generalized epileptic seizure, or it could be preceded by a number of feelings, a number of sensations that can pin down, that can direct you whether this is a seizure, whether this is syncope, or if it is a seizure, what part of the brain is generating the seizure. Patients with mesial temporal lobe epilepsy or mesial temporal lobe seizures can present with a feeling of deja vu. Some patients will report an olfactory hallucination, such as a burnt toast smell before they go into a seizure. There are patients who will tell you about a metallic taste before they have a seizure. Some patients experience a lot of fear. So, seizures that originate from the amygdala can present with a lot of fear at the onset. Patients who have seizures coming from the lateral temporal lobe sometimes will report vertigo. Some of those patients will report basic elementary sounds like knocking or ticking sounds. And patients who have occipital lobe seizures can have visual changes. So, those could be positive visual changes, such as seeing sparkles, bright lights, wavy lights, sometimes even seeing vivid images, versus negative symptoms where patients briefly lose vision in one of their hemifields. So, some of those questions will help you determine whether you're dealing with a seizure, and if it is a seizure, what part of the brain is generating the seizure. Patients who have a vasovagal syncope often will say that they start getting a tunneling of vision. Many patients will tell you that they feel that they're going to faint. There are some patients who report fullness in their ears and a feeling that they're going to just pass out. So those questions will help you, the answers to those questions will help direct your diagnosis. Now, once you have gotten some good answers to the first question, the second important question is, what happens during the seizure? If a patient loses consciousness or awareness, he or she may not be able to tell you what happens during the seizure, and for that very reason, you want to talk to family members and witnesses to describe what happens during the seizure. If they are not able to, if they are not very specific, you can ask if the eyes deviate to one side, if the head turns to one side or the other, if there is more shaking on one side as compared to the other side, because if there are lateralized finding, it may help localize and lateralize the seizure onset. Patients who have occipital lobe seizures sometimes present with a lot of eyelid blinking. So if there is a lot of blinking going on, you may suspect an occipital lobe seizure. Lip smacking, swallowing movements, hand automatisms are all seen in patients with temporal lobe seizures. Forced head deviation and forced eye deviation is something that is seen with frontal lobe seizures. Patients who have myoclonic jerks or quick flinging like motions before a generalized tonic-clonic seizure, if those are the symptoms, you may suspect generalized myoclonic kind of an epilepsy, such as juvenile myoclonic epilepsy, which will start with myoclonic jerks preceding the tonic-clonic seizures. Patients may space out for 20 to 30 seconds. So sometimes if the witness is not able to describe the seizure in detail, I specifically ask, besides the tonic-clonic activity, besides the motor activity, besides the shaking and foaming from the mouth, have you ever seen this person spacing out or blanking out or zoning out? And this is something that may not be considered a seizure by a lot of people. And unless you ask that question specifically, you will not have a very good answer. So, spacing out episodes, myoclonic jerks, lateralized motor activity is something that you will only know about if you ask some very specific questions. Now, then the next question is what happens immediately after the seizure? If the patient gets paralyzed on one side, what is called a torts paralysis, how long does it take for the patient to come back to normal, to be fully aware? If the patient just snaps out within a few seconds, you wonder if that episode under consideration was an epileptic seizure or not. But if the person is disoriented and is unaware of the surroundings for another 5 to 10 minutes, that makes it more suspicious for an epileptic seizure. The other thing to specifically think about is if a person is not able to speak for, let's say, another half an hour after the seizure, you wonder if the seizure came from the dominant hemisphere, which is the left hemisphere in most instances. Some patients will say that immediately after the seizure, they are not able to articulate themselves or speak. And again, that tells you that it might be the dominant hemisphere that's affecting the language. Another question that you want to ask the patient is, do they have a tongue bite and did they lose control of their bladder? And that is again something that will point towards an epileptic seizure. Okay, let's move on. The other question you want to ask is there any diurnal variation? So what does that mean? Diurnal variation means that if the seizures tend to occur more frequently during any specific time of the day. So there are seizures that may occur exclusively in sleep, as you may see in some frontal lobe epilepsies, or seizures that occur exclusively early in the morning, as you might see in some patients with generalized epilepsies. Diurnal variation does not give you an exact and accurate classification of the seizures, but can help direct you to the seizure types and towards the classification of epilepsy. Now, another question that I often ask patients is, have you ever woken up with a tongue bite or loss of bladder control? I have come across many patients who will tell you that they've been seizure free for a number of years. Actually, what is happening with some of these patients is they have unwitnessed seizures in sleep. And when you specifically ask them this specific question about tongue bite or loss of bladder control in sleep, it is only then that they realize that this has been happening a few times a month. And if these patients are brought in for video EEG monitoring, many times we find that the tongue bites and the incontinence is associated with unwitnessed seizures. So that is an important question to ask your patients. Now, another important question is asking about risk factors for epilepsy. So was there any complication at the time of the birth? Was there any febrile seizure in early life? History of CNS infections such as meningitis and encephalitis, history of significant head injury such as depressed skull fracture or intracranial hemorrhage. In older patients, you may want to ask about history of stroke, history of any brain tumors or brain cancers, because all of those may predispose a person to having seizures. An important question that is often overlooked is the social history. And social history is important. You want to ask what is the educational level of the patient, because that, number one, helps you counsel the patient with regards to their seizures without overwhelming them with too much information. I always ask about a history of alcohol use and smoking and history of recreational drug use. Alcohol, as you probably know, interacts with a lot of anti-epileptic medications and can metabolize the anti-epileptic drugs, making the person more vulnerable to have ongoing seizures. And the patients need proper counseling with regards to that. Another important question is asking about the job of the patient, the occupation of the patient, what kind of work do they do. Basically, what you want to counsel them about is, if in the event that the patient loses consciousness or loses awareness at work, they don't put themselves in danger and do not put anybody else at danger. You want to counsel patients against working in situations where if they do lose consciousness, they do not hurt themselves or hurt somebody else. Asking about family history is important. Certain epilepsies, as you know, run in families. Uh, so, getting a proper family history is important. Family history about neural tube defects, family history about other neurological conditions, as well as family history about epilepsy. It's a very simple question. Everyone asks about allergies, but it becomes more important with anti-epileptic drugs, because if someone has had a Steven Johnson syndrome in the past, if someone has had a severe allergic reaction in the past, you do not want to re-challenge this patient with the same anti-epileptic medication. Regardless of what you get in your referral letter, always ask the patients as to what medications they are taking, what kind of formulations they are taking, and what is the doses, at what times do they take these medications, and of course if they are compliant with taking their medications or not. When getting a history of about medications, it's important to ask the patients what medications they've tried in the past and what was the reason that that medication was discontinued, whether it was lack of efficacy or was it side effects from the medication that was the reason that the medication was discontinued. Another question to ask the patients is, what is the longest that they've gone without any seizures? And if somebody tells you that although the seizure free period in the last few years is only few months, but in the past they've gone seizure free for few years, you want to specifically ask what medications or what combination of medications they were taking at the time that they were seizure free. So I guess, there are a lot more questions that we can ask the patients to get a proper history. And I think because of the time constraints, I'm not going to go into all those details. But I hope the questions that we reviewed today, you will make it a point to ask your patients about those questions. This list is not exhaustive, as I said, but definitely you can make your own list of questions that you will ask each and every patient so that you can optimize the clinical history from the patients. Thank you for your attention, and I will stop here. If you have any questions, please feel free to add it in the comment section. And if you have any suggestions about topics for the future, please make sure that you put it in the comment section, and I will see what I can do to make a video on that subject in the future. Thank you so much.